Welcome. On behalf of the American Heart Association Center for Health Technology and Innovation, thank you for joining us today for this conversation titled For Classroom to Care, Building AI-Ready Health Professionals. My name is Dr. Bernard Esquivel, and I am a physician trained in immunology and medical genetics, and I currently serve as CEO of Genexus. Our work focuses on deploying clinical decision intelligence at scale, particularly through the agentic prescribing platforms that integrate artificial intelligence into real clinical workflows to help clinicians deliver the right medication for the right patient at the right time. Over the past several years, I've been deeply involved in the implementation of AI-driven solutions across healthcare systems, working at the intersection of precision medicine, clinical decision support, and responsible AI adoption. Throughout this journey, one of the questions that has consistently fascinated me is not simply what artificial intelligence can do in healthcare, but rather how clinicians and health systems can meaningfully adopt it in a responsible, safe, and effective way. And that is exactly what we'll be exploring today. AI, artificial intelligence, is rapidly becoming part of the healthcare ecosystem. We are seeing AI apply in diagnostics, workflow optimization, clinical decision support, imaging, predictive analytics, and even the administrative processes that influence patient access to care. However, technology alone does not transform healthcare. Transformation happens when people are prepared to use it responsibly. So the real question is not only how advanced the technology becomes, but what does it actually mean to have an AI-ready health workforce? How do we prepare students, clinicians, nurses, and healthcare leaders to understand the capabilities of AI while also understanding its limitations? How do we integrate AI into clinical workflows without compromising safety, accountability, or professional judgment? These are not only technological questions, these are educational, cultural, and professional questions that affect the entire healthcare ecosystem. To help us explore these questions, I am honored to be joined by an outstanding group of experts representing clinical practice, informatics, and healthcare education. Let me briefly introduce our panelists. Dr. Lisa Kitko is the Dean of the University of Rochester School of Nursing and Cardiovascular Nurse Scientist, whose work focuses on advancing nursing science and preparing healthcare workplace for emerging technologies in medicine. Dr. Wendy Chapman is a leader in biomedical informatics and artificial intelligence research at UT Southwestern, with extensive work in clinical informatics and implementation of AI within healthcare systems. Dr. Antonio Cabrera is a pediatric cardiologist at Nationwide Children's Hospital and a recognized leader in cardiovascular medicine and clinical education, with extensive experience mentoring and training the next generation of cardiologists. Before we begin this discussion, I would like to invite each of our panelists to briefly introduce themselves in their own words and share a bit about their perspective they bring to today's conversations. Dr. Kitko, perhaps we can start with you. Welcome.
Yes, thank you. And thank you for having me. It is great to be part of this conversation and on this very important topic. And I think both as a nurse scientist, as a dean, as a clinician, I kind of bring that tripartite focus in my perspectives as we're looking at preparing the healthcare workforce of the future, and really thinking carefully about how technologies like AI will shape our clinical decision making, our patient outcomes, and most importantly, I would think what I deal with mostly on a day-to-day basis is how we prepare the next generation of our workforce. So happy to be part of this discussion. Thank you for having me.
It is a pleasure having you, and thank you. Can't wait to get your perspective on the topics that we'll be discussing throughout this webinar. Dr. Chapman, please go ahead.
Yes, hi, I'm the Chief Learning Health Officer for UT Southwestern and also the Associate Dean for Health Informatics. And my goal is really how do you bridge research to practice? There are many AI tools out there that are developed, and almost none of them make it into care. We understand a lot of the gaps there, but it's really hard to solve. So that's my passion.
Happy to have you on board. Thank you so much, Wendy. Dr. Cabrera, the floor is yours.
Yeah. Thank you, Bernard, and I'm really honored to be on this panel. I'm a practicing pediatric cardiologist and cardiac intensivist. I do heart failure transplant at Nationwide Children's Hospital, which in the world of children's hospitals is the third largest children's hospital in the United States. I also hold an appointment at The Ohio State University as professor, and over the last many years, I've had the privilege to be part of the education of many trainees who want to become cardiologists. Specifically, a part of my career was spent at Baylor College of Medicine and Texas Children's Hospital, where I led the fellowship program for about 10 years, and having a in-depth experience and exposure to what are individuals who want to become cardiologists are seeking to learn, and how tools that are in evolution need to be adapted towards their learning, and how the learner needs to adapt to taking on those tools. My work requires high tech in the ICU and requires low tech in the clinical domain, where I examine patients and have discussions with families.
Fascinating. Thank you, Antonio. And it's going to be amazing also to get your input from the translational component, from the utility, clinical actionability, and then how to train upcoming, in this case, cardiologists. Thank you so much. So now that we have heard from each of our panelists, let's move into the discussion. What I would like to do is start by directing a question to one of our panelists, and then obviously, for everyone, invite others to share their perspective as well, so that we can build a broader conversation throughout this webinar. So following the same order, Lisa, let me go directly to you, and I would love to begin with you. So you're deeply involved in preparing the next generation of healthcare professionals, as you mentioned.
Yeah.
So from the nursing or overall educational perspective, how should we begin to formally define AI competency for clinicians? And what should be embedded into training today to ensure we're not creating a literacy gap in the coming years?
Yes, yes. And thank you for that question. And I'm excited because as we as a panelist got to know each other, I think that you're going to see, a lot of corollaries here that that are going to span the entire workforce. I think what's very important to recognize is that this is different. AI is different. Similar to the esteemed panel, I've been in nursing education for a long time. And we've seen lots of technology that has changed the way we educate students. But what is very different about AI, it's simply not a new technology entering healthcare. It really represents a shift in how information is generated, how we interpret that information, and how we integrate it into clinical decision-making. And when you think of that from that lens, AI competencies, it's truly a competency. It's right. It's not a new technology. We really have to think about what being competent in AI means for our for our students, and then ultimately our clinicians. So really, our focus has become on preparing nurses to understand, interpret, and critically evaluate AI-supported information within the context of patient care. So we at the University of Rochester, and I know broadly, from other colleagues as well, we really focus on three key domains. And the first is really foundational AI literacy. Nurses, at the bedside, although, Wendy may disagree with me, they don't need to become data scientists per se. We hope that some of them do, right? And they know how to do that. But they do need a conceptual understanding of how AI systems work, how the models are trained, how data influences predictions, and where biases or limitations may occur. And with that foundation, it's really important, I think, to set that foundation, because they're viewing AI outputs as objective answers rather than probabilistic tools that still need to require interpretation. So we are starting this very foundationally. I would say, oh my gosh, time goes quickly, but it was just a few years ago when we were, this is the demise of every health educator, right? And we can't have AI in our classrooms, and students will never be able to be competent. We have moved away from that very quickly, and we are embracing that. We use AI tools in classroom assignments. We examine how AI affects students' clinical reasoning as they're learning. And we're preparing students to work with emerging technologies in healthcare. What's very important, and I think what is very promising about AI, is we are using it as a clinical reasoning support tool, but we've also really had a big shift in focus on maintaining that human-centered nursing practice, or really any practice of our clinicians as well. I think the second bucket is clinical integration, and we're going to hear more about that, right? I think that you're going to hear more about, tools are developed, but they're not being adopted. If we do not teach our learners how to embrace this as a foundational skill, we're not going to be able to clinically integrate that into their workflow. Folks are going to see this as something extra. I don't understand this, so I'm going to be very nervous to do that. So I'm excited to be part of this panel and hear from the other group. We are trying to say this is going to be clinically integrated, and this is how it's going to help your workflow, and this is what you should be listening. This is what you should be doing. And then finally, I think the third domain is professional accountability and governance. Ultimately, regardless of what comes down the road next, in addition to AI, clinicians need to remain responsible for the decisions that they make in patient care. Nurses need to understand that ultimately they are responsible, and to be able to interpret the bias and the equity. So we've worked really hard to introduce all of these concepts and develop scaffolding learning experiences where students are exposed to this more throughout the curriculum. This isn't a standalone, let's talk about AI today. We have thoughtfully integrated this through the competencies in our curriculum. And to get to your second point, if we don't do that, right, we will have a two-tiered workforce. We will have those who understand how these systems work, and those that are expected to rely on them without the training to do so, and they're not going to be professionally satisfied or practice at the level that we want them to be practicing.
That's fantastic. Thank you, Lisa. Let me briefly bring Antonio. I want to hear your thoughts, from your expertise and focus, and may I even say passion about, training upcoming future cardiologists, and bringing into context, cardiology per se. Cardiology is a specialty, it's a medical specialty that utilizes technology, right? A lot of technology, but then it's purist in terms of clinical trials, in terms of, patient-physician interaction is one of the purest, I would say that. I would love to hear your thoughts about, what Lisa just helped us to understand and frame from the educational component, and then something around your daily life. Are you being challenged by your residences, by your residents? Are you being challenged by the curricula on how to embed this into how you're training future cardiologists?
Thanks, Bernard, and thanks, Lisa. Yeah, we're being challenged in very different ways, though. I do think that AI is the new name of how a machine processes data and gives you a result. I guess the first AI probably was a calculator with a AA battery, maybe an abacus. And the reason I'm saying that is that there's this demystification we have to do about what it really is. It's a much more sophisticated and likely more accurate approach to large amounts of information that, when condensed and associated properly, can produce a better result than if a human actually did it in terms of time or hopefully accuracy. That is sort of my sort of brief pedestrian definition of what this is. How do we redigest that in the present day? Well, we still tell people to use their stethoscope, right? But but statistically, if you ask people who are in training, if they have to decide between using a stethoscope or using an echo probe, you probably are going to find some people who may not use the stethoscope first. And this has been an important transition period for the specialty. In my line of work in the ICU, we manage babies who are born only with one ventricle, and babies who have single ventricle heart disease or have ventricles that don't squeeze very well with heart failure tend to deteriorate rather quickly and sometimes subtly. We have, as opposed to adults, in which you have a little bit of time to see how the data trends are going to show you sort of in which direction they're going. They're very subtle and sometimes beyond two-dimensional data that has precluded us from making the diagnosis of early deterioration before cardiac arrest, for instance, in babies and children who have this kind of problems. For the last probably 10 years, as I was a fellowship training and during this time, I think I've been a division chief now for 7 years. I have seen the more standard incorporation of scoring systems that are derived from machine learning at the bedside. There are particular vendors that do that in the pediatric space, and it has become pretty universal that the regular telemetry, plasmography, and regular linear data, it's just that they're not enough.
Mhm.
So how do we move from my judgment is what makes the difference at the bedside with experience to I have a scoring system that says that things are going to be bad soon, although they're not all bad at the moment. First, we have to understand where the data is coming from. So the computing is only as good as the quality of the data goes in. Number two, the algorithm has to work. So there are trials in adult medicine, actually in sepsis and actually atrial fibrillation and heart failure that have shown that if you use machine learning, you can anticipate actually when these patients were going to get sick way before than when they actually showed up. And there's also the interpretation of data that already exists that is considered two-dimensional. For instance, electrocardiography alone is a tool that has been around for a while, and we tend to interpret it in a sort of two-dimensional way in general cardiology. But what we've learned is that the displacement of certain waves during certain times shows that there are changes in the ventricular function and strain in the heart muscle that otherwise we couldn't see unless we had a continuous echo probe and we're just measuring that all the time. And that is already incorporated at the bedside. So we are training physicians to make clinical decisions not only based on their mileage. We are asking for them to incorporate some of the monitoring data of these platforms that allows us to actually anticipate and hopefully mitigate what on time the higher frequencies of cardiac arrest or clinical deterioration. How do we know that people have learned that though?
Mhm.
Being exposed to something doesn't mean that you know it. Recently, I think in the last in January, the AGPC published a piece of how to incorporate AI into ACGME, and similar to competencies that we use for training cardiologists, sort of the from the early to medium to expert, if you will, or can practice independently. They make the case that AI should be taught similarly, in which you can be literate but not that involved, so you understand and you understand the limitations and the functions of AI. You can be advanced, in which you can actually think about this in a different type of application, or you can be someone who's an expert and actually code or generate information in a different way. So I think that as a healthcare sort of bedside people, we have the opportunity to actually validate some of these tools, or actually find what their better use is to refine our decision making, not just to replace it. And at the very end, like Lisa said, somebody has to be responsible for the decision that's made. And in our case, it's not going to be the monitor. It's going to be the individual who is ultimately admitting a person for a problem.
Brilliant, thank you. And I will definitely, double click later during this webinar around accountability and co-driving or driving this side of technologies. Wendy, I would love to get your perspective, continuing before we change to the next subsection of this conversation, continuing with the educational lens. At the beginning of this webinar, you mentioned that you have seen, quote unquote, handful, just a bunch of or a few, solutions that actually can, be clinically actionable at a clinical grade and deployed, effectively. So I would love to get your input if the educational component or components that we're discussing right now are an element for that adequate implementation at scale.
Yeah, I think it's a really important part. And I mean, it ranges from like formal education to just workforce development and literacy, like you were describing. I think that the it's partly that the clinician's work is changing because of AI. It's also the patient's role is changing in the healthcare system. And so it's a new world. I feel like the typical educational initiatives that we do and approaches are important to continue, but we also need some new ways of educating. For example, we don't know how to best implement, predictive analytics or things into care. There's no recipe book, like here's how you do it. And not only that, but what works in one culture and in one, environment may not work in another, whether it's because of different data, different workflows, different cultural practices. And so there always needs to be a lot of customization. So I think a big part of the education should be in the co-designing and validating the right way for your environment and bringing students to the table instead of giving them a lecture, here's how we implement AI. It's like we don't really know how to implement it. So why don't you, multidisciplinary group that includes a computer scientist and informaticists and the, medical students and the nurses and whoever, like, here's a problem to solve. What would you do? And give them that environment to build new things, try new things, test it out, and learn things like, oh, that didn't fit into the workflow. I can see why that wouldn't work. Or oh, we put up this alert and they didn't even notice it. What's the
Hmm.
best, interface for it? Or we gave this information in the form of a number, point 0.7, and the nurse didn't know what to do with it. Or is it the nurse that really needs it, or is it someone else that needs it? How do we, there's so many questions about how you implement it. And I think giving them that creativity and that problem solving would not only teach them better, but they would come up with some solutions that could be really great for an organization.
I love it. I love it, mostly coming from someone that I used to, interact with top executives across healthcare systems. I love the fact that you're mentioning early involvement for students so that we can have a dialogue on better ways and to implement this type of technologies. And I agree with you 100%. Like all of you have been doing this for a long time, where the clinical piece converge with that technology. And it's about flexibility and bringing this technology into their workflows rather than trying to make them jump into yours. So that flexibility and ergonomics is a must for adoption and decrease friction. Let me stay with you, if that's okay, Wendy. Let me zoom out right now, and focus on the larger scale, zooming out from education, continuing with implementation. So from the perspective of health system leadership, what are we currently measuring when it comes to AI adoption? And what should we actually be measuring to determine whether AI is truly improving healthcare delivery overall?
Yeah, thanks. I liked what Antonio said that, this is a tool. And we've implemented many, many tools in healthcare over the centuries. And to some extent, we've evaluated whether they work well, and in others, we haven't. But there's more urgency, I think, with AI, both because of its power to disrupt, but also the speed and ubiquity of it. And so I think one of the main questions that health systems are asking is, are we getting the value for the investment? AI is very
Mm,
expensive. And what is value? What do we really want from this? So I think that the learning health system is a model to really help us do that continuous evaluation about the value, where we are observing what's happening in practice, and we can observe it through with people or through data, and we're learning from that about what's working and what's not. We're making improvements and changes and iterating it in that way. And sometimes we might decommission things, sometimes we might improve them. It depends on what we see. So I think there are a lot of studies about AI. And there was a post this morning by Eric Topol about the few number of RCTs that have been done. I don't know that that's the gold standard for evaluation of AI. Um, I think there's probably different ways we could measure. But what the studies have really focused on is clinician experience, which is important, and some on decision making. But we're just at the beginning of deciding whether they provide value. There was a really good paper that came out last week, a Viewpoint paper, about measuring the return on investment for
well,
clinician facing artificial intelligent technologies. And it points out that we're still struggling to determine which tools are worth the cost. And those costs are money, time, and political capital. So I asked our CMIOs here what we're measuring things because we implement these tools and they generate a lot of data and we know the amount of time people are spending on them, who's using them and who's not. So there's a lot of data that we have, but what are we not measuring yet that they want to measure? And I wanted to share a few of those with you. One is, how is AI changing the relationship between physicians and patients? That's an important question. It's not easy to measure, and you can't just get it from your EMR data. But although you can probably get some things from it. Why are some clinicians not adopting certain AI products? The adoption rate is still quite low, depending on where you are. And, what can we learn from why they're not adopting it? Another one is that AI is generating text that's going into the medical record. And are there practices that people have that will have unintended consequences, like if they copy forward some of that text, and now it starts to be repeated often, the kind of note bloat idea. Now you're amplifying some of the AI observations or findings that may not be the most important, being able to monitor things like that. And then finally, how is AI charting changing our training of residents? And how is it changing the role of the attendee in ensuring that students are learning that skill set? These are things that we want to measure, but are much more difficult to measure. But I think they'll be key in determining whether we're getting value from AI.
I love it. And wow, I mean, we could spend hours just talking about those elements that you just brought. And nevertheless, I love the lens that you're bringing that we can, discuss this on a multi-site healthcare, large healthcare system and defining, what's those quote unquote KPIs, success metrics when you're deploying something like this. But also this should be discussed on with every single intervention so that we can measure this. So to your point, randomized control trials, I get what Eric is saying. I think it makes sense at the bigger scale of implementing AI right now. But I'm not sure if you need a randomized control, an RCT for every single deployment that you're doing at every single stage. So it's a fascinating thin line here. I don't want to step into your shoes, Lisa. Please share your thoughts around this.
Yes. Antonio, Wendy, all bringing up excellent points, right? And I think as we're looking at, from a very, from having, students in a university setting that are out of high school to, to PhD students, right? The broad swath of when we talk about competencies and how we introduce competencies around AI and how we educate, the next generation of our workforce across a spectrum. It has been a challenge. And Wendy, to your point, I think this is a great, interdisciplinary way to think about things. And we do have what we call an AI hackathon, where we put all of our students, including engineering, and you can see those, as you're looking around as what the students are doing as to how we integrate AI and how they want to see us do that, and they're solving real world problems. I do want to highlight our learners as they come in and as new learners, and Antonio, you probably see this, they are very eager to learn about these competencies. I think where our biggest challenge is upskilling our current workforce, and how they're going to be able to do that. We're thinking about that a lot as well. And Wendy, you talked about it through continuing education or professional development, and what that is going to look like. I also think that's a piece of this whole workforce training competency assessment that is going to be a big piece of this, and will determine how we adopt things or not, especially when we get out of areas where the majority of us are, right? When we get out of an academic health center kind of system, what does that mean, right? And how do we, train that workforce?
Thank you, Lisa. Antonio, anything you would like to add?
Yeah, no, thanks. I mean, this has been a lot illuminating. I mean, my life's relatively simple. I mean, you have to be really sick, could be in an ICU, and we get to see you, and we put machines when your heart doesn't work, and if things are not working well, we do more. So let's fast forward for a second. So, when I was I guess when I was a resident in the late 90s, I wrote notes, and the notes took no time. We have forms that we fill. We're done at 11 with whatever number of patients we had, and billing was a binder that we just checked and moved on. Then we moved to, oh, we got to type notes. And typing notes created a new burden to the clinicians, particularly who type less well. The ones who type well were fine. But turns out that the majority of people over the last 15 years who've been typing notes are done with it. They don't want to do it. And now it's actually a cause of burnout. And most physicians, even if you're good at it. So going back to Wendy's question about or comment about value, and a little bit about, Lisa's point about training the future. This is what I see. The learners we have right now are not that interested in spending a lot of time in duties that do not seem to be appropriate or lined up to their degree of their licensing that they believe is high. So, for instance, not functioning at the highest level of licensing is something that a lot of professions feel. So typing is one of them. So if you have a proprietary sort of AI tool that you walk into the room, you put your phone out there, like some of the ones that already exist, and then you see a patient and you have more time with the patient and you examine the patient. And by the time you get out, your note looks like a note, not like some crazy thing that somebody else typed, and your assessment is there. You're done with it. There's a huge difference from that to seeing patients in a rush, having the computer in between. Certainly, there's an opportunity for us to get closer to patients. Number two, as there is an opportunity, there will be challenges. So one of the potential elements that we're seeing is that with better monitoring, we get better at dealing with things that used to not work before. So if we have algorithms that allow us to prevent death, then we will have patients who are sick longer or sicker longer. And the ability to manage those patients is going to rest on the clinicians who know how to do it. Typically, not somebody who's very new. So when somebody tells me that, we're going to lose our jobs because AI is going to come in, I don't think so. I think that we're going to end up managing problems that are more complex, problems that we used to miss sometimes, and now we can manage, that we learn how to manage. The other one is how, at the end, the clinician, when we're all gone, when they're in their 40s or 50s, the people that we train, how are they going to practice medicine is going to be totally different to the way we do it now. This idea that making mistakes and errors is how you learn. Well, we're going to shave a good number of the errors by anticipation. So there will be a higher expectation as to we make less errors because now we know how to prevent them. So I see this creating some burden on the learners, and maybe the last part is actually helping the learners have adaptable skills to all these changes. I mean, we certainly are having to acquire some of this adaptable skills, but I imagine that the kind of population they're going to take care of are going to be more technology dependent, chronically sick, maintained for longer. And that is a new set of patients that a lot of people are not used to taking care of. We have to teach people about how to manage patients with long-term compassion and technology assisted that go home. We do that in adult medicine. I mean, I think the adult cardiologists are very good at sending patients home with VADs and all those things. But this is only starting. I mean, we're going to prevent stroke. There's randomized data of machine learning algorithms that can anticipate and prevent stroke events in patients with atrial fibrillation. I mean, this has been done. So although the data on cardiac arrest prevention is not quite there yet, I think at some point it's going to happen. We're going to learn how to use these algorithms to prevent things. And that's going to be very challenging because that paradigm in the ICU has been for a long time. We have to do enough, but not in excess. Don't overthink it. Don't go overboard. There's a downside to over intensifying someone. And where the balance will be, as to, we keep all these very sick folks alive and hopefully well and going home. It will be the task for the next many years, learning how to do that.
Fantastic. And you just brought so many interesting points that we can spend hours here. I know you need to go back to your job, If not, I would love to stay here for hours and keep talking about the things that you brought. They are fascinating. Let me just stay with you if that's okay, Antonio. I love the fact that you were actually mentioning actual tools from note takers, that they are a reality. I use them on my clinical practice. I use them outside of my executive roles as well. I use them nowadays. But you went all the way down even to other realities that are happening, like the home hospital, quote unquote, right? And how we can actually outcomes that we're seeing that are better in terms of keeping the patient at home from many factors that you brought as well. So you're talking about diverse solutions, AI enhanced, AI driven, AI augmented solutions that are already outside there, and we are learning how to articulate those into our day-to-day clinical practice, patients' outcomes, and then making informed decisions either proactively or when we need to actually prescribe or treat right away when a problem is happening. Let me go back to the fundamentals here, and I want to prompt this question to you. Again, going back now from your educational component as someone who trains physicians, how should we prepare clinicians to responsibly, I'm going to highlight that word now, responsibly engage with AI tools, particularly around trust, accountability, and clinical judgment arise? What those elements, how can we start framing how to train them and tackle trust, accountability, and clinical judgment for AI tools?
Yeah, thank you. Number one, we as leaders have to do the studies that actually validate the use of this tool. Number one. Number two, we as leaders have to show them how to learn. Just being adaptable is not enough. The number three, there's a big issue, I think, that we haven't talked about, which is, although AI platforms have been used for entering text, particularly of work products or manuscripts. In most large organizations that produce science, and I'll speak about my role at the American Heart Association as chair of the Young Hearts Council, was to believe that humans should write their own abstracts. And there is an element about that, and it's an element about that the fact that when you probably use your computer to correct the text with an editor tool, that's fine. All of us use that. But when data is produced or interpreted or modified by AI tools, that is in direct conflict with the ethics of work being original. And I do think that a lot of organizations who may not have, tools that allow them to see, if abstracts have been generated through machines alone, they may be seeing some really fantastic text that may not be true. So the focus on high productivity alone that we've had for years, I think, in part, you got to live in a confidence interval on the bounds of ethics, but in part, it's pushing people to, in a way, produce things. Having said that, I think that I don't want to predict how we're going to shift, but I think eventually we're going to have to accept that some data that we see in manuscripts and abstracts is going to be adjusted and perfected by a machine. The data may not be, but the text is probably going to be. And how do we adjust as organizations to actually pick that up? How do we give value to the individual that actually spend more time during that? Effort has value, right? But these tools actually reduce the friction that it takes to have a good abstract, for instance. It sort of depersonalizes initially the idea of this is your own work. and gives individuals a sense of efficiency that might be misplaced. The last part is, you know, when a decision is made and the interpretation of the tool was incorrect and the outcome is negative, are we going to go back and say, well, it really wasn't my judgment, it was that I saw that signal? I think that that is a part we have to teach, the part in which what is the role of this information, but because ultimately, as caretakers of individuals who entrust us with that, they're not entrusting their lives and their healthcare to algorithms or machines, at least not yet. So because we are that person, we have a covenant with the patients that we will do whatever it is that we need to do to help them live. And with that, I think it will challenge the paradigm in which we currently live as, well, there are probably parts in which the machines will be better at flagging you that when you need to intervene. But ultimately, the responsibility over that life resides on the person at the bedside.
Thank you. And I have a very specific follow-up for you, Lisa, around your level of comfort by, data being adjusted by machines. But before getting there, Wendy, I would love to hear your thoughts about enterprise implications of accountability. What is happening out there? Are we actually finding ways to properly frame accountability and limits and who is responsible for what when we are deploying or implementing AI solutions in a healthcare system setting?
Oh, that's a good question. I don't think I'm an expert in that space, but of course I'll give my small opinion. Um, I did give a talk. I moved to UT Southwestern from Melbourne, Australia, and I was invited to give a talk to the, like the association for all of the judges there. And it was about that topic. They wanted to know if a case comes to our courtroom that involves AI, what should we be thinking about? So I did a little bit of reading at that time, thinking about that. And there's so many different aspects, but ultimately it's, yeah, what's the duty of care that someone has? What's the standard of care? Standard of care changes. So, if you did, it may be the standard of care to not use AI, but eventually it's going to be the standard of care that you're using AI. And by not using it, maybe you're responsible for the error that you had. Um, there there's questions about, I mean, my husband is also in this field, and he is also a patient who's had a lot of, cancers and chronic health problems because of that. So from the patient side, he's wondering, why are the recordings being thrown out? And whereas you get this summary, this note, which leaves out a lot of things, and is there information in that recording that was valuable to the care, and could that be an issue to worry about? I don't think we know the answers to these things. We already have case law about duty of care with devices and other types of interventions. Is it the same? I think it might be a lot of overlap with that, and who's responsible. So I think it's really complex, and time will tell.
Thank you. Thank you. Thank you. Um, Lisa, what are your thoughts? Would you be comfortable by accepting the fact, it's a little bit biased as you can imagine, but yeah, it's a great thing. It's a great way to spice things up here. Would you be comfortable by the fact that papers, publications, manuscripts are being fine-tuned by the machine, and it's okay? Probably, the quality, ideal scenario, Antonio, the ideal scenario where the quality of the data is robust, where there was a team working on this, the back science that drove that, it's there. How you poised it, it's been fine-tuned by a machine. Is that okay for you at this point of time, or not?
I think you saved the hardest question for last, Bernard. I think Antonio raised very, very significant, valid points, and we're talking about a lot about AI and integration in the workforce. But Antonio, when you went to thinking about AI and PhD and training the next generation of scientists, I think that's where we have an extreme amount of work to do. So Bernard, I don't know if I'm going to answer your question or not about how I feel about that, but I do think ethically training that next generation of scientists of how we use AI and taking that outside the pressures of a promotion and tenure and everything that we need to do to produce and we are seeing that now. I think this is, as I look across the university, been the most challenging for educators, right? It's probably a little bit easier to integrate AI maybe in training of clinicians, right? But when we think about the impact on AI of how we're training our scientists, I think that's where we should have a whole nother webinar just on how we're doing that and how we're managing that. That has been the most challenging for our faculty. And I think in a lot of the ways we've gone back to very traditional ways of education, right? Where you are in a seminar format and those students you're able to see that intellectual curiosity and development in real time. We cannot get away from that, right? I think that has to be an essential piece of how we continue. And we struggle a lot. I'm teaching an entry-level PhD course right now, Bernard and Antonio. The questions you brought up, we are dealing with on a very granular level, right? You can see it, right? Like, oh my gosh, this was an excellent peer review by a first-year PhD student.
Yeah.
This is, probably better than I would see from a senior scientist, right? So, really being able to do your job as an educator, and that's an easy way to say it, right? Do your job. I'm not quite sure what all that entails yet, but to really be training that next generation of educators. I'm from a PhD, I probably still a very purist, right? Grammarly, those kinds of things, Antonio, as you hit on, those are good for me, but we cannot lose that intellectual curiosity to having a sentence phrased the right way or made to sound more scholarly. And Antonio, happy to hear your. Oh, I'm sorry, Bernard, I'm taking over your roles, but this was a very intriguing part of this discussion.
Is there anything you want to add, Antonio, based on Lisa's comment?
Yeah, I mean, I think maybe what we have to remind people is the value of not just efficiency, but integrity.
Right.
And the sort of thought of by all means necessary, if you will, not by all means. The giving up on the very nature of the principal functioning of people will be a problem. And actually, how we foster that is that making it practical, that having integrity still has value. Having said that, having integrity doesn't mean not using AI. What it means is that when you do, you say when you used it and why you use it for, where the data came from. And I mean, the also having integrity about the data that gets processed by AI. One of the big challenges we have with clinical trials, and I'm sure you know it, I think it's actually on that AHA statement from 2024 on AI, is that if we look at ways to create a tool, for instance, to identify skin cancer, we're going to find that the majority of the people who have skin cancer tend not to have dark skin. So the tool will be able to identify individuals of lighter skin who have skin cancer, clearly producing a tool that works for the people that the data came from. So we need to be very specific as to what the data source of the tool might be. It's not the same data from the Framingham's study to data from other studies, right? So having a better understanding of the origin and the composition and the integrity of data will become more important than just the processing of it and its results. And the idea that, again, I think that how we teach this as a way to improve our decision making or improve the product of what we're doing, shifting what the outcome is. If the outcome before was you need to write really well in this paper, that may change a little bit, especially if the ideas that you're putting there of the problems you're trying to solve actually are sophisticated. But I think all of those eventually will continue to change, and we're going to put more value on on the final product of what this is trying to solve than how it sounds.
Yeah, 100%. And you brought something very interesting as basically you're indirectly referring to the quality of data and its implications with equity and access. And that's a whole different thing that also needs to be addressed as well. And I'm going to use that as a segue. We have several questions from the audience here. Let me bring something around close enough topic that is privacy. So one of our attendees from Brazil, by the way, welcome, asks, how do the speakers currently view the issue of privacy regarding such sensitive patient data as the sharing of health data with AI systems? I don't know how this issue is regulated in your countries, but have seen an issue as a problem for implementation and routine use of AI in the day-to-day practice of medicine here in Brazil. So in a couple of minutes, I open this question for anyone who wants to take the first shot and provide your opinion around this fascinating question around privacy. Yep. Go ahead, Tony. Thank you.
Yeah. In hospitals, most data of patients gets collected for predictive analytics or monitoring is de-identified immediately. And the challenge is that to if you have de-identified on a data on a ICU day, for instance, you also have the identified data on the echocardiogram, and you have the identified data on the chest X-ray. So there might be to associate the data of individuals who are de-identified, it's going to become challenging if you want to process that in sort of a supercomputer or sort of a data lake, which is sort of what we talk about. But yeah, internally, not a problem. Externally, a problem. Organizations that don't de-identify the patient's information are going to have a challenge. It is current practice in the United States to de-identify data. But I don't know that is a practice everywhere else.
Thank you. Wendy, Lisa, anything you would like to add around this topic?
I might add, just thinking about LLMs as a different case where, it's capturing a recording. That recording is going up to the cloud. And so I think a lot of health systems have created agreements with OpenAI and other companies and Microsoft to, that's your local space in the cloud. It's not going into general training for, these systems. So they're addressing that. But I do think that we get a lot of questions from patients and clinicians about where is my data going? How long is it there? And I don't think that the physicians know how to answer it.
Yeah, I think we should, hopefully we can have a follow-up webinar talking about sovereign data governance and the internal, external. I love that you brought that up, Antonio. That's crucial. You can do some things internally, and I think we have good guardrails. But when you're interacting with a third party, Wendy, someone that is coming in that is not part of your institution, there are many questions that need to be asked from the training data perspective, but how that data is handled, managed, administered, and overall taken care. I think we have. Let me just bring one more question from the audience, if that's okay with you all. I think we still have a couple minutes here. So this is the question, and anyone just chime in. Hi, Paul. Yeah, from Henry Ford Healthcare System, Detroit. Welcome. A very nice webinar. How ready the health systems are to accept AI platforms, tools, and practices. Next question is, what is the best model to charge the expenses to implement these AI tools? That's a tough one, probably, Wendy. Meaning, who will pay for it, and how insurance are approaching it. Wendy, you have you had your mic open. You want to help me with the first try to address this one?
Yeah, that article that I mentioned about ROI says, one of the big issues is that the people paying for it are not the people getting value from it. So that's something to think about. But I don't know how it's working with insurance, but it's a big question about, even with things like the patient portal and the time that's spent answering emails from patients. And now we have a charge model for that. So it becomes more feasible, but at the same time, more complicated. I don't know what other people's thoughts are about that.
Lisa, any thoughts around this?
It's interesting on the return on investment. I do think though, and Antonio, you talked about this a little bit, about ambient documentation, right? and practitioner burnout. I think there's, this is much more complex than perhaps a return on investment and who is going to pay for it. I can tell you from, these large health systems being able to retain the best practitioners, that we don't lose them to burnout, because they can spend the evenings with their family or whatever and not, do clinic all day and go home and chart all evening as soon as they have dinner. There's a return on investment in that as well, right? That is it's going to be much more difficult to measure from an organizational standpoint, but certainly critically important in terms of, retaining a high functioning workforce. And I think that's going to be an important piece of this as well.
Yeah. Antonio, anything you want to briefly add around this topic?
I don't want to be provocative, but I think that a well-applied set of tools in AI may actually reduce the earnings of a healthcare organization pretty significantly, because better management, better decisions involve better care. And if you do that, the length of stay is shorter. If you do that, the readmissions after being sick should be less. So actually, it might be counterintuitive to a lot of people, but I think that that's kind of what we've learned with other tools, is that we invested millions of dollars, for instance, in Epic. And most organizations did. Epic is a great tool for seeing things and for billing things. One of the elements that has provided is that you identify situations by looking at the vital signs and admission. They flag the patients the moment they get in, so you have a better idea of what you're going to see. So patients are more likely to be identified regardless of if you're junior, you're mid-level, or you're senior. This is going to create a set of efficiencies that hopefully level the playing field across the different types of an extent of experiences in healthcare. The last one is buying these tools. It seems like it's very onerous. You have to buy licenses sometimes that are for organizations, and the return on investment might be similar to what Lisa said. People are less burned out, but how you measure that is we don't go around asking the chaplain or the child life specialist what is the ROI on what they do. And there's certainly elements of artificial intelligence that may be subtle and that relate to, well-being that are not easy to measure.
Thank you very much. And you're bringing another fundamental question that is, should value continue following infrastructure, or should we actually pivot to value following outcomes, which might be a different way on how we can perceive value. But before we close, I would like to leave us with one reflection. Artificial intelligence will undoubtedly transform healthcare in the coming years, but technology alone does not transform medicine. People do. What we discussed today reminds us that building an AI-ready healthcare system is ultimately about education, professional responsibility, thoughtful integration into clinical practice. If we prepare the next generation of clinicians to understand not only how AI works, but how to question it, evaluate it, and use it responsibly, then AI can truly become a tool that enhances clinical judgment rather than just replacing it. I would like to thank Dr. Kitko, Dr. Chapman, and Dr. Cabrera for these insights today. And thank you to the American Heart Association's Center for Health Technology and Innovation for hosting this important discussion. And thank you everyone who joined us today. Have a great day.
Thank you. It was wonderful.
Thank you.
Thank you.